Hello, good morning. Help yourself to coffee, which I haven't made. So I'm going to try and go over the toxidromes and then go over MH in particular and the ECG changes, which I tried to find. So there's lots of different toxidromes which you can actually use this flowchart to try and differentiate between. But the easier way, I think, comes to in a bit. Toxidromes that are associated with hyperthermia cause not only CNS effects, but autonomic effects and neuromuscular effects. So malignant hyperthermia sits within these. So you've got serotonin syndrome, anticholinergic syndrome, sympathogenic and neuroleptic malignant syndrome, as well as MH. And I found this really helpful for revision, but basically MH is secondary to inhalational agents and sucks. That's the most close association. You get normal pupils with it, whereas with some of the others, you don't get normal pupils. So especially with anticholinergic. The other thing is the treatment is cooling, dantrolene, and paralysis. Those are the three. But prevention is better than cure, and we had a patient with query MH in obstetrics a couple of weeks ago, and we had to make sure that we had a vapor-free machine. We used TIVA as our primary approach, or regional, if we could, but it said she was quite difficult, spinal, so we were quite worried about that. So prevention is better than cure, but not always. So MH itself is progressive, but can also be life-threatening. And it's not only hypothermic, but it occurs during GA. So in terms of how many people actually have MH in the UK, 2.8 million people undergo a GA in the UK. And out of those, 1 in 50,000 have MH. So 1 in 50 to 1 in 100,000. And the susceptibility is 1 in 3,000. So it's quite a lot of our population could have a susceptibility to malignant hyperpyrexia. So maybe it's something we do need to think about a bit more. In terms of the etiology, as most of you know from the MCQs, it could be due to the ranitidine receptor. RYR1 is the most common on chromosome 19. And it's autosomal dominant. So family history is really important when you do an anaesthetic review. I don't know whether you can see this, it doesn't project that well, but basically in terms of the pathophysiology, it's to do with the calcium handling. So what happens here is that you have an inherited disorder of your skeletal muscle due to autosomal dominance, which I've talked about. And what happens is that the calcium threshold is actually changed. So the threshold of calcium that is required to cause sustained muscle spasm is decreased. So those people are more susceptible to a sustained muscle spasm. And what happens is that you have a prolonged interaction between actin and the myosin within the cell, which means that you actually have increased tetany. I've talked a bit about the triggers, but one of the other things that can trigger it is stress. So the stress and anxiety of surgery, especially if they're already susceptible, that can actually cause it. People who don't have to be under GA to have MH. So the vapors and sucks aren't the only things that can cause it. So malignant hyperpyrexia is very rare to happen without GA, but it can happen without GA. So preoperatively, I've talked a bit about the equipment. Use non-trigger agents and think about regional techniques, and talk to the patient themselves about what's going to happen and the risks to them as a result of this. And think about having dantrolene and knowing where that is in hospital. So within the actual intraoperative period, apart from having your increased end-tidal CO2, which you can see from the graph. You can also have people who have quite muscle spasm, they have rigidity, and you can get that even on induction, so they can have master spasm, etc., which can make it difficult to intubate. So that's another thing to think about, especially if you're giving like sucks. So for an RSI, so it's another thing to think. I don't know whether anyone's come across that already. Yeah. So you can have other things that you can have. You can have an increased respiratory rate to try and compensate for this. You can have metabolic respiratory acidosis on your blood gases, and profuse sweating. But this can sometimes progress to cardiac arrest as well. So you can have ECG changes, etc., due to a hyperpyrexia. So you can get lots of different ECG changes, and I was trying to look at what you can get. And apart from like, you know, sort of like right bundle branch plots, etc., you can get ST elevation, depression, all the way through VF and VT. So there's no like specific pathophysiology for this. We don't really know why this is happening. I was just curious as to whether we see something specific. So as you can see, you can get all sorts of ECG changes, and sometimes it can be, might have to go down the cardiac arrest algorithm as well as thinking about the baseline causes and thinking about dantrolene as well. So one of the things that is postulated, one of the hypotheses, is that it's a hyperkalemic driven ECG change. So the cardiac impact and the ECG changes you're seeing in electrical activity, etc., is because of the hyperpotassium. That would sort of make sense with the succinylcholine being one of the triggers, maybe, I don't know. So, but it's not the only thing that can happen. There could be other things going on, and it's always important to think about differentials. One of the things that I was thinking about is anaphylaxis can present in a similar way. You can have thyroid crises and the other toxidromes. So is it a malignant neuroleptic syndrome or serotonin syndrome or something else going on, not just MH, but MH is something that's drilled into us. So the treatment is pretty like straightforward. It's very protocolized. You call for help, think about ABC, think about the trigger, stop the trigger. You can hyperventilate them on high flow oxygen, but it depends where you are in the surgery. That might not always be an option. Depends on what's happening. Are they open on the table? Usually the cases that I've read about tend to be immediate rather than in the middle of the procedure. But that might not always be the case because not all people react the same way. So you have to think about treating what you're seeing. So treating the hypothermia, treating the acidosis, and treating the arrhythmias. And the way to do it is to think about giving dantrolene early as possible after doing immediate management of ABC. Think dantrolene if you're thinking MH. And that should hopefully help with the hyperkalemia, try and correct the hyperpyrexia, and any other metabolic acidosis. And later on in ITU, you might see myoglobinemia as well, so you have to think about that too. And DIC. So this patient will need to go to ITU, HDU setting afterwards. So this just breaks it down. And the things that, apart from increase in CO2 and tachycardias and increase in oxygen requirements, temperature changes are the main thing that you do see in MH. Like I said, you need to think about where you are in the procedure, tell the surgeon, communicate with the surgeon about what's happening. And you can muscle relax them actually, which is strange to think because the muscles are the ones that are causing all of this to happen. But you might be use a non-depolarizing agent like rock or atracurium. So dantrolene is 2.5 milligram per kilogram, and you can have it on most cardiac arrest tollies. Different hospitals will be moving around, so different hospitals have it in different locations. If you have multiple theatres, like at Heartlands, we have multiple dantrolene on the different cardiac arrest trolleys or in recovery. But it's important to also, as an anaesthetist, you have to think about giving the patient a letter afterwards as well, and writing to the GP just like you would for anaphylaxis. And they come in 20 milligram vials, and it's quite difficult to draw up dantrolene. So it's just important to think about that as well. So the test that you do after you have an MH patient, so once they come out of ITU, you follow them up, you have to think about muscle biopsies, and there's an MH muscle biopsy centre. This is based in Leicester, I think, and one in London. And you can also do, well, we won't do it, but you can order a caffeine halothane contractor test as well. But the muscle biopsy is the most important thing. You can also do gene testing and gene tracing, so you can test their family to see whether or not they're susceptible to MH as well. So the one that I saw was basically not actually in hospital, it was pre-hospital. And as you can see, there were ST changes on the ECG when I was remotely monitoring. And this was a fit and well young man in his 30s, not allergic to anything and didn't have any previous GA issues at the time. So it was quite worrying to see this. So basically this patient was an analog astronaut in a suit, and he was on tizanidine. I don't know whether anyone's heard of that, but it's basically something they prescribe on the planet, on the continent, not on the planet, on the continent, for muscle spasm, and muscle pain. But we only prescribe it here it's only neurologists that prescribe it here for MS. So in Austria and in France, they prescribe it for generalized muscle pain, like paracetamol. And that can actually trigger off MH within like a closed suit. Obviously, in the middle of the desert as well, and his temperature got up to 42 degrees, so it was pretty high. And that's with ventilation, etc. So the in-suit temperature was only 37, so it was quite a high temperature for him. So these are my references. I can give you the slides. And this was a really good paper that I found if you're revising for exams. It's a CEA, CCP article, so you can literally Google it. And that's it. Cool. Brilliant. I need to go to theatre 3, so any quick questions?
I think there's only Leeds that do all the MH testing.
Is it Leeds? L or L? Leeds or Leicester?
It's Leeds.
Is it? Yeah. Cool.
It can be very helpful. I had a patient who's on my list who said her son had been diagnosed with MH, and she thought that she'd been tested, but she hadn't got any letter or anything on her. And this was like, she was tested like 30 years ago. So I rang them up and they went back through her records, they able to trace her and confirm definitely that she wasn't susceptible to MH. So I have run once or twice for other sort of similar type patients as well.
I think there was another one that was interesting because I had it at 3 o'clock in the morning, so it was an overnight night shift in Good Hope, and the patient said she'd been diagnosed with MH, but she was from another hospital, and we had to get everything ready. But getting a vapor-free machine at that time was quite difficult because in Good Hope is quite a small hospital, so we found that there was one in obstetrics, so you had to get the one from obstetrics down to theatre 3, and it's quite a distance, about half an hour away, in order to actually start a laparoscopy. So it was.
But you can take, as you said, you can take everything off the schedule management also.
Yeah, you can. So we did all of that. Yeah, but the consultant who was coming in wanted that machine as well, so it was quite difficult.